We'll wait for 2 to 3 minutes, Subbu. Shall we?
Shall we start, ma'am?
Yeah, yes, Lakshmi. Yes. Good evening, everybody. Yes, you start, Lakshmi.
Okay. Good evening, everybody. So welcome to the 6th session of our P3 series. So for those who need introduction, this is our program for postgraduates, and it's like the brainchild of our president, Madam Dr. Lakshmi Velmurugan, and the theme being approach to common pediatric problems. So we've always had full house, and it's been a very popular and sought after program for our postgraduates. We are very happy, and this month the topic is on nutrition in critically ill children. And to welcome our speaker, may I now request our President Madam to take over. Ma'am, over to you.
Thank you, Lakshmi. Respected Shija Sagunan Madam, welcome to this program. Madam is additional professor at SAT Medical. She is additional professor of SAT Medical College, Trivandrum, Kerala. She has been an active participant in most of the IAP programs in Kerala, and she's a very popular figure over there. Her areas of interest are immunization and nutrition and critical care, critically ill, tropical infections, and fluid and electrolytes. That's why we thought she's the ideal person to talk on fluids in critically ill children for the postgraduates. And she's, what do you say, during COVID period, she done a lot of original work in Missy, and whenever she is a panelist in dengue, or she's always a panelist in dengue and Missy, that's what I have observed. And any program in immunization where SG Kasi sir is a moderator, Madam will usually be there because a very great academician. Thank you so much for being with us, Madam. Over to you, Madam, for the next 50 minutes. Thank you.
Thank you, Madam, for those very kind words. So good evening, everyone. It's indeed a pleasure and honor to be here. So I thank the Chennai City branch for this wonderful opportunity. So coming straight to my topic. So I think the slides are visible now.
Yeah, yes, ma'am.
Yeah.
Yes, ma'am.
So what we talk today is nutrition in critically ill. So what I would be covering in the next half an hour or so would be, first we would just see that why do we want to discuss this topic? We are more interested in discussing a critical illness than a nutrition. So what is the importance of nutrition in illness? Then we would briefly touch upon the pathophysiology, what happens to your body during infections or during an illness. And then we would briefly go through some simple clinical scenarios and see how we can modify our practice. And finally, we will also look through the recommendations and look at how we can adapt these recommendations. Now, first of all, we need to know that around 15 to 25% of PICU admissions are malnourished in developing countries. And now the malnutrition includes not only undernutrition, but also includes obesity. And there is a high risk of nutritional deterioration during illness, and nutrient delivery during illness influences outcome. So we all knew that when you have a child with a severe malnutrition, when you had a child who's underweight, multiple studies have proven that it is associated with increased mortality, increased duration of hospital stay. But now there are multiple studies which are showing that what you are giving the child during the time of critical illness, starting from the day one of illness, influences the outcome. What does this we mean by outcome? Decreased delivery of protein and nutrient, that is less than what is recommended, has been found to be associated with increased duration of mechanical ventilation, increased duration of length of stay, not only in the ICU, but also in the hospital, and also increased incidence of secondary infections. So with this, we hope we do understand that nutrition plays a very, very critical role in the outcome of a child who's getting admitted into your ICU. Now let us see what exactly happens during critical illness. Why do we want to discuss it separately? During critical illness, there is a host of neuroendocrine responses because of which your anabolism is coming down and your catabolic hormones are going up. And the person or the thing that faces the most brunt is your skeletal muscle. It undergoes proteolysis and releases the amino acids. Why does it release the amino acid? And where does this amino acid go? One of the reasons why this amino acid acts in your body is it is used to synthesize the acute phase proteins. All your CRP, procalcitonin, interleukin, cytokines, they're often made up of protein. And this protein synthesis during an acute infection is happening from the amino acid that is being released by your catabolic muscle and not by what you are taking in. And on top of that, the cytokine storm also has a brunt on the liver. Liver goes on to have glycogenolysis and gluconeogenesis, increasing the glucose content. You would have commonly seen the children coming in critical illness, rather than having hypoglycemia, are often having very high glucose levels. And hyperglycemia is deleterious. Hyperglycemia is deleterious on multiple counts. Whenever you get a glucose on high, remember your shock correction is going to take time, because high glucose level is going to cause glycosuria, and the polyuria is going to result from that. And the increased glucose load acts on to the lactate load. That means you already have a lactic acidosis because of hypoperfusion. This glucose is contributing there. Hyperglycemia is also immunosuppressive, and hyperglycemia also increases capillary permeability. So hyperglycemia due to stress illness is deleterious, and also your adipose tissue is also not spared. It also undergoes lipolysis, and there is an increase in fatty acids and glycerol. So there are a lot of changes that are happening in your body during a metabolic stress. Now, what happens to the resting energy expenditure during an ICU admission? We need to know that initial phase of illness, in fact, the resting energy expenditure is less. That is, a very unstable child who's coming to your ICU is having a very less energy expenditure at that point. But soon the resting energy expenditure increases as the child stabilizes. And we need to know that even after recovery, even after your child is going out of the ICU, the inflammatory process may continue and hamper his nutritional improvement. Some of them may recover soon with the disease recovery. Some of them, the deleterious effects goes much beyond the initial critical phase. So we need to take care of the nutrition during the illness, during the hospital stay, and also post-discharge. So it is mandatory that every child who gets admitted to your ICU, we do take the weight, because we want to write the dose according to the weight. But it is mandatory that you do a nutritional assessment. Complete nutritional assessment, at least within 24 hours of admission, is mandatory, and categorize your children according to the pediatric nutritional risk score. You can use any score. Basic concept is that anyone with a severe illness is at a risk of going for a nutritional disability. And also anyone with a moderate disease, but whose intake is less, also is having a nutritional risk of mortality. So now let us see the first child. 2-year-old child with fever, lethargy, poor intake. Dengue NS1 has already been done from outside. It is positive. Child's vitals are stable. Mother, when you ask about the urine output, mother is not very sure. She feels that probably it is decreased. What do you want to do for this child? In clinical practice, you would have 101 reasons to prescribe a maintenance fluid. But remember, none of those shown in the screen are really indications to give a maintenance fluid. Why is it so? What are the goals of maintenance fluid? When we start a maintenance fluid, the real goal is to prevent dehydration, prevent electrolyte imbalance, prevent protein breakdown, and prevent ketoacidosis. We need to remember that your maintenance fluid does not contain protein, vitamins, or important minerals. There are no electrolytes. The major electrolytes are there. The sodium and potassium is there. The calcium, phosphorus, magnesium, your bicarbonate, these are not there. And any child who is on an IV fluid is going to lose 0.5 to 1% weight daily. On top of that, putting a child on IV fluid puts the child under other electrolyte disturbances like electrolyte disturbances, sepsis, fluid overload. So many complications can happen just because you have put that needle there and started him on IV fluid. And remember, your standard maintenance fluid provides only 20% of the required calories. The recommended, whatever be the recommended maintenance fluid, they recommend a fluid which contains a sodium between 130 to 154. That means you can use a plasma light or you can use a DNS, but it necessarily contains 5% dextrose. Now, 5% dextrose means 100 ml contains only 5 grams of glucose, which is going to give you 20 calories. That means a child who's 10 kg requires 1,000 calories in health is going to get just 200 calories. So every time we prescribe a maintenance fluid, this thought process has to come to our mind that we are prescribing only 20% of the recommended calories in health when you are pregnant. So whenever you have your stomach in place, whenever there is no contraindication for enteral nutrition, please use that. The gut is not only associated with improved nutritional supplementation. That means the baby does well with an enteral nutrition compared to a parenteral one. But also remember that gut has lymphoid tissue, which provides you better mucosal immunity, and it is associated with improved survival. Every time you're keeping a child nil per oral, you are making the gastric acid, the intestinal juices are still continue to secrete. And while these are secreting, your mucosal atrophy is happening because intestine is one place where local nutrition also plays an important role in the integrity of the epithelium there. So once there are stress ulcers formed, you're going to have intestine is never a sterile zone. Bacterial translocations happen and risk of infection also goes up. As your pes patches atrophy because of decreased nutrition, your gut-induced or gut-derived immunity also comes down. So remember, enteral nutrition is beneficial for the mucosal integrity and motility. It is associated with decreased infectious complication. It prevents bacterial translocation through the gut. Caloric needs are better met, and early enteral nutrition is associated with decreased mortality, decreased duration of ICU stay, decreased mechanical ventilation, and less organ dysfunction. So benefit of an enteral nutrition far encompasses what we normally think about it. Now coming back to our child was in dengue febrile phase. In the febrile phase, as far as possible, please do not write fluids. Encourage oral intake, especially electrolyte-rich oral fluids. Your kani water with salt, your ORS, your milk is preferably given, because remember that it is over as the disease progresses, the child usually goes in for hyponatremia, and hyponatremia also favors fluid leak into the interstitium. So always electrolyte-rich fluids and feed is what we recommend. Avoid IV fluids as much as possible in case there is a GI contraindication and you are forced to write a maintenance fluid. Let it be just 1.5 ml per kg per hour, not your 3 ml per kg or 4 ml per kg per hour. Just ensure the urine output is 1 ml per kg. Because remember, even in health, when you're giving a crystalloid, only 25% remain in the intravascular volume, 75% is going to go to the interstitium. And in dengue, the capillary endothelium is grossly damaged. There is leakage of not only fluid into the interstitium, even the proteins leak into. So in health, 25% remain in the intravascular volume, whereas in dengue, when the capillary endotheliopathy is severe, in sepsis also, only 5% may ultimately remain in your intravascular volume. And what goes to the interstitium needs to be cleared by the lymphatics. If more fluid reaches there, your lymphatics cannot clear. And as the child moves into the critical phase, ultimately you reach a place where the child is in shock, but the child is grossly puffy, the child is hypoxic, and there are too much of fluid, and you are in between hypoxia, hypoperfusion, as well as uncorrected shock. So that starts from day one of management. So as far as possible, please do not put them on IV fluid early in the course of illness. Now coming to the second case, the 2-year-old child with nephrotic syndrome. And since he's a nephrotic syndrome, steroid dependent, you're thinking he's immunocompromised. So in spite of having a bad X-ray, decide to provide him with an NIV. Now the question is, for this child on an NIV, do you want to start an IV fluid or do you want to start an enteral feed? Remember that for patients who are on an oxygen support, there is no scientific evidence of increased feed intolerance or bowel ischemia. Start feed as early as possible. If for this child you have just kept an NIV, you are not sure whether you would finally land up intubating, you want to decide for the next 1 or 2 hours your course of action, you are justified in not starting the feed at that particular moment. Because you may require an intubation, and during the time of intubation, you do not want the baby to aspirate. But after putting the NIV, you find that your child is settling down, you don't have any plans to intubate right now, please start the feeds as early as possible. And we usually start once the decision is taken within 1 hour, because you normally, when you keep someone on NIV, by 2 hours, you have decided what you really want to do with the baby. And if you feel that the child is going to be on the NIV, ensure every time an oxygen support is provided, please ensure that NG tube is also there. Often what happens, the baby gets admitted to the ICU, you have kept an oxygen support. After some time, you feel that, oh, should I start the feed again? You go and disturb and then put an NG tube. Don't do that. All the noxious stimuli you're going to go for a baby, please do it together. While the baby is getting admitted, have that NG in, along with that oxygen catheter in whichever way you are going to provide. Because this is going to help in multiple ways. If the child is having an abdominal distension because of the air going into the stomach because of your NIV, you can use the same NG to decompress. One of the commonest reasons of intolerance to non-invasive ventilation in children is because you keep them nil-peru. Remember, children, if they are fed well, they are not like us. They don't have anticipations that I am feeling a pain, I'm feeling that I'm supposed to be hypoxic. No, if they are just satisfied, if you are able to satisfy their metabolic demands, they are the most cooperative ones. An irritable child always means that the disease illness is more than what you are anticipating, provided his gut is also full. So please ensure that the NG is there and you start the feeding upfront. Remember, when you do a fasting for whatever reason, and the starvation that is happening in illness is not the same. Starvation in illness is totally different from starvation when you are well. When you're illness, when you're starving, when you are not taking food or not giving food, in fact, there is severe protein catabolism. And naturally, we already said catabolism is there, protein synthesis is not happening. On top of that, the blood glucose goes up, and all this leads to salt water retention. This is something, as for anyone who's working in ICU knows, that we are extremely scared of a puffy child, because water retention is something which hampers each and every organ in your body. So that is something that you don't want. And the poor nutrition is associated with significant hypoalbuminemia. We all know, yes, albumin has a half-life of 21 days. Yes, albumin comes down early whenever there is a coagulopathy, because albumin can shift to the interstitium. Yes, albumin is an acute phase reactant. But all these are aggravated. Hypoalbuminemia is aggravated when there is starvation happening in illness. Same thing does not happen when a healthy person starves. So keeping this in mind, always remember to start feed as early as possible. Because, as I already said, it causes muscle weakness because muscles are breaking down, the catabolism is happening. It also causes decrease in surfactant production, so your respiratory support is going to escalate. There is a decreased response to hypoxia. The patient finds it difficult to compensate for the problem he is having. And all this is also contribute to impaired immune response. Remember, nutritional deficiency associated immune deficiency also happens here. And decreased circulating albumin, as I already said, causes increase in extravascular lung water. So don't take nutrition lightly. Start feed as early as possible. When should you start? The recommendation is to start within 24 to 48 hours. In our unit, when you have ventilate, even for those who are undergoing invasive ventilation, after the first hour of invasive ventilation, that means you've taken a repeat X-ray, you have decided no tube repositioning or no other things are needed, and child is hemodynamically stable, straight away the feeds are started. So hypoxia or a respiratory support should not be a reason to delay feed. As I already said, if there is a dilemma whether you would require an intubation for an NIV, that would be the only reason. Always minimize interruptions as much as possible. Now, what happened to our child? We started the patient on enteral feeds through NG tube, but unfortunately, the pneumonia progressed, the respiratory distress worsened, and the child went in for a septic shock. Now, what next? So now you have a septic shock. Can I continue feeding this child? Well, the answer is, if the patient is on vasoactive medications, enteral feeding should not be given incompletely, because we all know in shock, our body's mechanism is to cause a splanchnic hypoperfusion so that more vital organs like your brain and your kidneys are getting blood. So when the perfusion in your intestine is not enough, at that time, if you go ahead and give a full feed, you are going to worsen the splanchnic ischemia, and which can also cause pseudo bowel obstruction, abdominal distension, vomiting. So this is one condition where early feeding is not recommended. So what do you mean? When do we start the feeding? Are we going to wait till the child is off the vasopressors? No. Once the shock correction goals are achieved, that means once the BP has picked up, while the child is still on inotropes, please start the feeds. Not full feeds. Here, we would start with the trophic feeds and slowly escalate as tolerated by the patient. But start feeds within 24 to 48 hours of admission to the ICU, even if the patient is on an extracorporeal life support. Now, trophic feeds, what do you mean by trophic feeds? Small feeds. If it's an infant, it's 5 ml 3 hourly. In an older child, it is 1 ml per kg 3 hourly, usually not more than 20 ml. Now, what is your goal? So we said we are going to slowly increase, or we said we are going to give 2 hourly feeds. What is your really goal? What are we aiming to achieve? Are we aiming to achieve the recommended daily allowance, a 10 kg child, 1,000 calories? Or are you going to aim for a resting energy expenditure, more than the resting energy expenditure or less than the resting energy expenditure? We need to know that the energy needs of a child who is in your ICU and a child who is playing at home are different. A child in ICU is not growing, so he does not need energy for growth. A child in ICU is not running around, so he doesn't need energy for his activity. A child in ICU does not require the thermogenesis part also. So that also is less. Because the diet itself is less, like diet-induced thermogenesis is also less. And the basal metabolic rate itself is less because of the adaptation the body takes, and the body is in a controlled environment. So normally, you do not require exactly what is not totally recommended in a normal child. All you require is somewhere near the resting energy expenditure. Now, we need to know that this particular resting energy expenditure is not same for everyone. For a child who has undergone a cardiac surgery, the resting energy expenditure may be just 40% of the normal. A child, on the other hand, a child with burns, the resting energy expenditure may be 150 times or 180 times more. So resting energy expenditure also depends upon what disease you are taking care of in the child. And you should know that both overfeeding and underfeeding are equally deleterious. So you have formulas like Schofield formula to calculate the resting energy expenditure. You have the WHO formula also, but these formulas are highly inaccurate and really do not predict. So what is the ideal method? Ideal method is indirect calorimetry. Direct calorimetry nobody does. But in most of the ICUs in India, we don't have this privilege to use an indirect calorimetry. And we should know that now the newer GE ventilator, in fact, tells you what is the respiratory quotient and what is the average energy expenditure. So just imagine nowadays you have ventilators who are going to tell you what is the resting energy expenditure, because the respiratory quotient is the oxygen consumed and the carbon dioxide produced. So why is carbon dioxide produced taken as a indicator of your resting energy expenditure? Because remember, whether it is carbohydrate, whether it is protein, whether it is lipid, they all contain the carbon molecule. Once they are oxidized in your body, they are going to release carbon dioxide. So the amount of carbon dioxide released by the body is also an indicator of the resting energy expenditure when coupled with the oxygen consumption. So if you have a ventilator or an indirect calorimetry and you're able to calculate the respiratory quotient, it so beautifully tells you whether you are underfeeding the child, overfeeding the child, or adequately feeding the child. So this is the Schofield equation. In general, what is the requirement? In general, I would say normally we would go with a 55 calorie per kg per day for a child in ICU, along with 1.5 gram per kg per day of protein. Protein intake from day one is important. Too much of calories are not needed because, as we already said, usually the resting energy expenditure is less. Now, what are you going to give as feeds? Give the normal feed. If the mother is breastfed, start with EBM. If the patient is not breastfed or you don't have a thing to give through your NG tube, you can use the standard formulas and can be given. But remember that a child in an ICU, so usually what happens? You have an ICU, you have decided to give an enteral feed. You will write all the medications, you will write all the other drugs, and then whatever, and already the child will be on 2/3 maintenance. So what is left of the fluid, you give it as the feed. So a 10 kg child may be hardly getting 30 ml too hourly because all the other fluids is being used up for your medicines. And we forget the nutrition then and there. We are not usually bothered about this 30 ml too hourly for a 20 kg child. What is the calorie it is providing? What is the protein it is providing? Am I reaching the target? So we need to have a habit of at least writing that down. What is the calorie and protein I'm giving today? Am I able to increase the calorie intake over the next couple of days so that as the disease progresses, as the child improves, my caloric intake is also going to improve? Remember the first slide where we said that the inadequate protein intake with increased duration of mechanical ventilation, increased mortality, and increased secondary infection. Secondary infection is the most dreaded complication when you see a patient in the ICU. So now our child, you said all the history, all the theory, started the feed. You're slowly trying to escalate, but unfortunately, the child develops abdominal distension and vomited parts. So what do we do? So our knee-jerk response would be nil per oral, start IV fluid. This is what we commonly do. Don't do that. Always see why is the patient not tolerating the feed. If for an 8-year-old child, you have prescribed a complete milk-based food, he will not be able to digest all that milk protein because you don't have so much of disaccharides sitting there. It may be because your patient is on NIV and there's too much of gas inside your air inside your stomach, which may be the reason why he's vomiting. If it is so, all you need to do is that in between the feed, just aspirate the air. The problem is solved. It may be that you have not taken care, we have not thought about the bowel movement. The child is constipated for the last 5 days. Yes, he would have problem in that. So just see that just keeping a Dulcolax suppository or adding a laxative to the prescription may improve your feed intolerance. So find the cause and treat the cause. That's very important. If in spite of all this, and also remember, if the patient is on muscle relaxant, if the patient especially on high dose opioid, that may be the reason why the feed intolerance is happening. See if you can come down on the opioid. See if you can stop the opioid and use an alternative analgesic in that case. So all this needs to go to our mind. Prokinetics may be used, but it's not of proven benefit as of now. Now, next part. How do you watch? So our child has vomited. So we decided that we will go from continuous feed to from an intermittent feed to go for a continuous feed. Now, continuous feed, where do you want the NG tube to? Do you want it to be a gastric feed or do you want to be a post-pyloric feed? Ideal way of doing a post-pyloric feed is you have weighted NG tubes and you put it in under the fluoroscopic guidance, or you can take an X-ray. What we normally do is use the same NG tube. We will insert a 4 to 5 centimeter more and take a chest X-ray and see that whether the NG tube has reached the duodenum. So you can go for. What is the advantage of a post-pyloric feed? The advantage is that the chance of aspiration is less because you are delivering the feed directly into the duodenum. So a reflex of the feed chance is very less. What is the disadvantage? You cannot give a bolus feed because your duodenum is a very small place. It cannot accumulate too much of feed once at a time. So you will have to give it as a continuous feed. So if your patient has no risk of aspiration, gastric feed, whether bolus or continuous, is completely recommended because that is more physiological. But if there is a chance of aspiration or the child has already vomited, you can always opt to go for a continuous feed by putting a nasoduodenal or nasojejunal tube. So now the next question. Should we regularly monitor the gastric residue? There was a time when we would do that. You 2 hourly feed and before every feed, you would look whether there is a gastric residue and then decide whether the feed needs to be continued or not. Please do not do routine monitoring. Your child has vomited, the child is showing abdominal distension, yes, check for residue. But if the child has no symptoms, don't do, because this act itself may be the only reason why your enteral nutrition is getting interrupted or becoming inadequate. Yes, the transition may take some time. The gastric motility may be slightly low because of the drugs and the disease, but it usually gets absorbed. So unless the patient shows a symptom or a need for you to look for the gastric residue, please do not go ahead and look for the gastric residue. Now, if the patient has a feed intolerance, abdominal distension, and you check for a gastric residual volume, you can, in fact, what are the times when you would like to check the gastric residual volume? You find that the abdominal distension is increasing. You have measured the abdominal girth and it seems to be increasing over 2 consecutive times. If the patient has vomited more than 2 times, yes, you must look for the residual volume. And if the residual volume should be considered significant, if more than half the previous feed is present, or more than 5 ml per kg of feed is left behind. So what can you do? If you were right now giving a 3 hourly feed, you can make it 2 hourly feed so that each feed is less in quantity. Or instead of going for an intermittent feed, you can opt for a continuous feed. So stopping the feed should be your last option. And you can also hold the feed for 2 hours. Child has just vomited twice. Okay, wait for 2 hours. Then after 2 hours, you clinically examine the child. If you want, you can aspirate and see no bile aspirate, no intestinal obstruction. If an X-ray is needed, you would do that. No, nothing is there. You may start the feed, but this time maybe with a lesser volume or maybe as a continuous feed. Now, what about proton pump inhibitors? We didn't say anywhere regarding that, right? When the child vomited also, we said so many things, but there was no proton pump inhibitor there. And this is something we often find a habit of writing. Don't write. Why? Because when you use a proton pump inhibitor, you're completely suppressing the acid production in the stomach. Always remember that whatever God does is for the benefit. So never try to antagonize it. The acid sitting there is going to prevent the bacteria entering your body. It's a protective part also. It helps in digestion also. Why do you want to then suppress it? So avoid writing it routinely. Write a proton pump inhibitor only if the patient is having a GI hemorrhage or the patient on high dose steroids and you feel the patient's risk of a stress bleed is high, then you can write a PPI. Routinely for every patient admitted to the ICU, don't write that. Writing a sucralfate would be much, much better. Now, the commonest cause why your child is doing bad nutritionally in an ICU is not really due to feed intolerance, but due to feed interruptions. There are again umpteen number of excuses we find to interrupt a feed. Abdominal distension, stop feed. And somebody has vomited once, stop feed. Planning an imaging, stop feed. Planning an LP, stop feed. So for everything, we seem to have a surgical consultation. Usually the first thing they write is nilparul. So there are so many reasons we find to stop feed. But the study shows that most of the interruptions in the feed are avoidable. You are planning to extubate the child 3 o'clock in the evening. Why do you want to stop the feed at 5 o'clock in the morning? No, right? So we need to have a protocol that exactly how many hours before extubation you want someone to be nilparural. For a procedure, do you really need a 6 to 12 hours feeding? And if you're planning a small surgical procedure, how long can you feed? We need to know. We need to know that even for a surgery, clear fluids can be given up to 2 hours. Breast milk can be given up to 4 hours of a surgery. That means a GA. And formula can be given up to 6 hours prior to the procedure. So stick to these rules so that the interruptions to feed are less, so that the adverse nutritional impact does not happen. Now, our child unfortunately went in for a coagulopathy, DIC, modes, day 4 of PICU. Now, should I start parenteral nutrition? Because my child has, now I don't have the intestine. Till now, I was telling use the GI to provide the feed. But now I don't have the GI. So should I start parenteral nutrition? So again, here you need to know which is better, early parenteral nutrition so that the patient doesn't deteriorate, or you want to go for a late parenteral nutrition, which is better. In fact, when you start an early parenteral nutrition, as the graph shows, you can see that the late parenteral nutrition is the pink one and the blue one is early parenteral nutrition. So naturally, when you're starting an early parenteral nutrition, you are achieving your target of calories, your target of protein earlier than the group who is going to achieve a late parenteral nutrition. But paradoxically, when you look at the outcome, early parenteral nutrition was associated with a longer duration of mechanical ventilation because longer duration of hospital stay, longer incidence of acute kidney injury, and longer and higher incidence of bloodstream infections. Why is it so? So it is because you are probably overfeeding the children early in the illness. As I said initially, the initial hyperacute phase, the patient's resting energy expenditure is in fact less than 50% in most cases. And overfeeding may be deleterious that time. So what is recommended is start a parenteral nutrition preferably after 1 week of PICU stay. If after 1 week of PICU stay, you're still not able to achieve the target calories and protein, do consider parenteral nutrition. And it may be starting with a partial and then progressing a total parenteral nutrition. But if your patient is already malnourished, then don't have to wait for 7 days. By the 4th or the 5th day, it would be preferable to go for a parenteral nutrition. But early parenteral nutrition is definitely not indicated. And as you can see here, so how can we overcome all these hurdles, right? We set so many hurdles, and how can we overcome? In fact, each unit, each ICU should have a protocol for nutrition. We have protocol for shock, we have protocol for seizures, we have protocols for almost everything under the sun which comes to the critical ICU. But very often we neglect or we do not have a protocol for nutrition. And this study beautifully shows that when they introduced a protocol for enteral nutrition, there was a significant decrease in interruptions of enteral nutrition. There was a significant decrease in use of parenteral nutrition, and significant proportion of patients achieved the energy target earlier when the protocol was introduced. The unit was same, the doctors were same. They were thinking of doing the same thing. Everyone wanted an early enteral nutrition, but nobody was objectively monitoring whether the amount of calorie the patient is receiving, whether the protein is receiving. But when you do all that, you can achieve your targets much better. So a simple method of doing that would be any child who comes to your ICU, first question, can I feed him enterally? Do I have the stomach or the intestine available for me? If yes, is this a candidate for him I can give full feeds, or is this a candidate I cannot give full feeds? If I can give full feeds, depending upon the fluid need, I will start with 2-hourly or 3-hourly bolus feeds. But subsequently, the day 2 or 3, please reassess your calorie intake and protein intake and see whether you need to modify what you are giving. You may be giving EBM, but the calorie and protein might not be meeting. So you may have to modify it, like say 3 feeds of EBM, then 1 feed of a formula which is isocaloric, which contains 1 calorie per ml. So unless we monitor the protein and the calorie intake, we are not going to modify what the child is getting. On the other hand, if it is a child who's not yet ready to go for a bolus feed, say someone on shock, again, I said once the shock is corrected, immediately start them on trophic feeds. Trophic feed, we already said it can be 1 ml per kg 3-hourly, or the trophic feed can be a continuous feed, 0.5 ml per kg per hour, but not more than 20 ml per hour. Every day you will reassess the child and see if there is any gastric intolerance. How is the baby doing? Yes, the baby is fine. You go on increasing the feed every day till the target is achieved. Our aim is that at least by day 7, the target has to be achieved. Now you decided to give the patient a feed, bolus feeds or full feed, not trophic feed. Then you have to ask yourself, is my child under risk of having an aspiration? Is this a baby who was previously admitted with an upper lobe aspiration, or is this, say, a child with a cerebral palsy who otherwise is also having feeding difficulties? If there is an aspiration risk, it is better that you go for a continuous feed. Here we said you can use either nasogastric or nasojejunal feeds. So here start with 1 ml per kg per hour, give it for 4 hours. You can check for the gastric residual volume if you're anticipating an intolerance or if there is an abdominal distension, and then advance accordingly. If you are not able to attain the target over a period of time, then see why you are not able to achieve. So do you want to use a pro-motility drug? Is it because the child is constipated, you want to do something there? Is it that you are giving bolus feed and the child is not tolerating, should I move to a continuous feed? Or is it a child I need to supplement with a parenteral nutrition? So once we follow an algorithm like this, you would be able to give a better nutrition to most of your patients. So before I conclude, this is one thing that we cannot forget. Because every month we see a child, at least one child or more than one child with severe malnutrition. We're not talking about moderate malnutrition. And severe malnutrition comes to you not because of poverty. Severe malnutrition comes to you because of the faulty feeding techniques. Now, for this child, when it comes to your nutrition, extremely important to remember that whether this child is going to go out of your ICU healthy will depend upon whether you're using that NG tube in the nose or you're using that cannula sitting in the hand. Remember, every time you are going to put this child on an IV fluid, he is going to receive only 20% of his calories. So this is a baby who has come to you with malnutrition. You are aiming to give him 100 calories per kg per day, and you are now starting him on a maintenance fluid and giving him only 20 calories per kg per day, that too without any proteins, and you're pushing the child further into the malnutrition. We will find it extremely difficult to make that baby survive. So however sick the child looks, our primary aim should be to use oral whenever possible. And until and unless there is a contraindication, there is no indication not for giving a feed. If a child is having a diarrhea, the purge rate is very high, you may decide to rehydrate him parenterally, but you would still continue the feed. If it's not tolerating 2-hourly feed, go to hourly feed. If it's not tolerating hourly feed, don't hesitate to start that continuous feed. He badly needs it because that is his only way of survival. And for this child, if for some reason you need to put a maintenance fluid, remember these babies cannot tolerate extra sodium. So you cannot put them on DNS. You cannot put them on half DNS. There is the only indication now for using an isolate P in your ICU. So these children, you have to be extremely careful and do not resort to parenteral nutrition in them. Do not resort to high protein in them. Remember, the small amount of protein which is present in F75 is to ensure that the enzymes are first secreted. Only after the enzymes are secreted can you increase the diet. So these children badly require oral feeds or enteral feeds. Only then we can expect them to go home like this over a period of time. And finally, nutrition should not stop at the time of discharge. You can see this child at the time of 3 months of discharge. Look at the amount of catabolism the child is having. A case of a very bad toxic epidermal necrolysis who went in for a secondary infection, ARDS and multi-organ failure. At the time of discharge, completely emaciated. He still has an NG in place. He has a tracheostomy there. He can hardly sit. You're literally making him sit. So your nutritional rehabilitation starting from the ICU should reach your ward and should reach the home also. To see the baby 3 months later walking around with a much, much better nutritional recovery is truly satisfying. So the take-home message, opt for enteral nutrition whenever possible. Hypoxia or oxygen support is not a contraindication for enteral feed. Start feeds early, not only to keep them healthy, but also to decrease the duration of mechanical ventilation, decrease the incidence of secondary infection. In children with shock, enteral nutrition should be cautiously started once they are hemodynamically stable. Do not measure routine gastric residual volume. Always keep a track of amount of protein and amount of calorie the child is getting. Always ensure that every child in ICU is getting at least 1.5 gram per kg per day of protein. Wherever you have a risk of aspiration, never hesitate to go for a post-pyloric continuous feed. Thank you.
Thank you. Thank you so much, ma'am. It was such an excellent session. It's an offbeat topic, but still we have had enough of participants. Our magic number is always 100. And though it is for critically ill children, INCU care, intensive care. So only the instead of the practitioners, the postgraduates are interested. Still, we had around 800 participants with YouTube and with this link. And this YouTube link, the recorded program will be in the YouTube also, madam. It was really tough topic made to sound very easy by you, madam. I really thank you. Now we have a lot of questions. I think Lakshmi, can you just go along with the questions?
Yes, ma'am. I'll just go through the questions that have popped up in our chat box. So we have two questions which are kind of similar. So one is relating to malnourished children, one is relating to obese children. So in these categories, do we calculate the caloric requirement for the actual body weight or for the ideal body weight? This is the question.
Okay. In malnourished children, there should not be any doubt because we always start with the current body weight. We are not going to look for the ideal body weight. Because a malnourished child in an ICU, in the initial days, you just want him to survive. And subsequently, you want him to grow. And then your nutrition requirement, the calorie intake will go. So at the time of admission, you're just looking at 75 kilocalories per kg per day. By the second or the third day, you would be increasing to 100 calories per kg per day. That is the current weight. So you're not going to look at the ideal body weight. Now coming to obesity, that is definitely a very difficult question. Obesity, you would initially feed with the ideal body weight. And what you're really aiming is for obese children also, see to it that they are having adequate protein. Protein intake is mandatory because critical illness, it is always the protein that is getting lost. But always aim for a hypocaloric diet. So there you would go for an ideal body weight, and here you would go for the actual body weight.
Thank you, ma'am. I think it was very, very clear. Now we have another question. So what is the advice on replacing NG feeds when the aspirate is more than half of the feed volume?
So if you have a NG aspirate of more than half of the previous feed, I would say wait for 1 or 2 hours. So see to it that the patient is comfortable, the abdominal distension is not worsening, you're not having an ileus there. See to it that your electrolytes are normal. One of the commonest causes may be an associated hypokalemia. Sometimes what we miss is a hypophosphatemia. So look for that also. Magnesium, phosphorus, calcium, potassium. Your electrolytes, which are important for your motility as well as your neurological status. So once you have taken care of all that, you will start the feed. You're not going to replace what is aspirated. you are going to start the feed with a volume less than the previous feed, so that you feel that you will see whether he's tolerating that. If he's not tolerating intermittent feed, we will just go for a continuous infusion feed. So you replace and aspirate. The question would happen like, for example, you have a continuous NG aspirate. There we would be replacing it with an IV replacement rather than with a feed. So feed is always intolerance and tolerance. I hope I made it clear.
Yeah.
Yes, ma'am. Thank you, ma'am. And then do we have, this is actually my question, do we have established consistent definitions of feed intolerance across PICUs yet?
No, not exactly. Not exactly. Because even this, as I said, feed intolerance is initially definitely a clinical diagnosis. That is, clinically, you find that the child has vomited, there is an abdominal distension, you think of feed intolerance. As I already said, it might not be always a feed intolerance. It might be just because there's too much air inside the abdomen because of which he's vomiting, or it may be a gastric motility issue which can be managed otherwise. But normally you would say that if it is more than half the previous feed, you would take it as a intolerance.
And any role of nutritional biomarkers, albumin, lactate in monitoring?
No, no. I would say that you can definitely look at these things, but they are not exactly in a critical illness. You cannot equate them to the nutritional status, because we all know that albumin is very difficult to use, because albumin in critical illness always goes up, goes down. And that is the reason, because the albumin is going to the interstitium because of the capillary endotheliopathy that is happening, whether it is sepsis, whether it is any kind of a cytokine storm, or in dengue. Everywhere the albumin is going to come down. So albumin is not going to tell you about the nutritional status. Lactate, no, because lactate is a marker of your tissue hypoperfusion. Lactate can go up due to other conditions. Hyperglycemia may also be a reason why the lactate goes up. So these kind of biomarkers would really not help us.
Half-hearted parenteral nutrition, just giving amino acids. You don't want to give TPN, you don't want to give intralipid to avoid sepsis and all that, just giving amino. Most of the time people do resort to it. What is your take on it, madam?
I think that's a very, very nice question. So here what we need to understand is that when we are giving amino acids, we are really aiming at what? We are aiming at a protein synthesis. We are expecting that when I'm giving my amino acid, my child is going to use that amino acid to form the protein. But before doing that, we have to always see that the calorie intake is also adequate. Because if the calorie intake is not adequate, this amino acid is going to go for gluconeogenesis rather than for protein synthesis. So once the calorie intake is also adequate, definitely, if you're not able to achieve, we can give amino acids. So especially when you have a malnourished child. So pre-existingly itself, the patient is malnourished, or a patient is already there for more than 7 days and you're not able to completely achieve, then we do think of adding an amino acid. But I would always say, like, for example, you have, it is a child you are putting on a maintenance fluid. So instead of D5, you may think of using a fluid which contains D10, so that at least the calories that is receiving is more. But whenever you are increasing the dextrose, you have to check the blood glucose. If you have 2 values above 180, you would require an insulin to be coming there. Only then that glucose is being used for anabolism. So amino acids may be used not as a routine, but in select situations we may use.
Okay. Continuous feeds when you are giving, do you experience any difficulties, madam? Because NGT, otherwise most of the time the practice is stop feeds. So usually this is not, usually this continuous feeds is not practiced by many of us. Do you find any difficulty or any practical tips for more?
This is something that we do very commonly. We do very commonly, because especially I would say that malnourished, a SAM child coming to you, the commonest reason that you'll end up in the hospital is with the diarrhea. Then it becomes, and you are going to give the oral feed as well as the ORS orally. The baby ultimately lands up tolerating neither. Both of that doesn't tolerate, and you resort to IV fluid. So our practice is the moment the baby comes, you put an NG, you start with 2 hourly feeds, not possible, go for a continuous. It's extremely safe. Only problem is that have a big label telling that this is for NG. Because you are keeping that in a 50 cc syringe. A new sister comes, who's come for a change and shift, she may just connect it to the IV. And this is not a rare phenomenon. There are multiple literature reports of this happening. So if you're using your syringe infusion to go for a continuous feed, see to it that it is labeled as an NG fill very boldly so that nobody does it. We haven't, madam. It is very useful. I would always encourage to use that.
Okay.
Not,
Any
you don't have to
practical
really go for.
tips? Anything which you do this, it's easy, something like that, madam, connecting it to a syringe infusion and then
We just connect it, but like for example, previously the child was receiving say 40 ml 2 hourly. So we would go for 20 ml hourly of a continuous feed. And we won't give it for 24 hours. We will give it for 4 hours. After 4 hours, it's a 1 hour break because your intestine also needs a rest time and your intestinal juices also need a rest time. So it goes continuously for 4 hours. Then you give break for 1 hour and again give for 4 hours. So sometimes what we will do when the mothers are not reliable, morning time we may be giving these 2 hourly feeds. Night time we'll put a continuous feed because these babies, you cannot take a chance with nutrition. So that is also we can practice that daytime intermittent continue. You're not reliable, go for continuous feed, but extremely useful. If you're able to get that NG tube into the post-pyloric region, it's not mandatory. Just going
what
by
do you use commonly, madam? What do you use commonly in a continuous feed?
milk. Commonly we use milk, but
any
what
particular that high fat, something like that, or just regular?
Usually we always start with the regular milk. The high calorie milks are available. 2 companies are making high cal is there, and 2 companies which give you isocaloric, that is 1 ml 1 calorie. Sometimes it's not available and the patient finds it difficult to afford. Then what we do is to a 30 ml of feed, we just add 1 ml of coconut oil. That itself will make it isocaloric because 22 calories in 30 ml. So that would take care of the nutrition.
What we do for a newborn,
yes,
we are not able to purchase HMF. Okay. Okay, that's what
if we are giving, if the mother has enough breast milk, then definitely EBM is given like that. EBM is also given as a continuous feed. So both we give. EBM also we give as a continuous feed and also formulas we give as a continuous feed.
Any other questions, Lakshmi?
Ma'am, actually, the other questions Madam had already presented. The NPO period before a LP or a minor procedure in the PICU, I think Madam did address that. And what all feeds can be given in the NG? It is a repetition of what Lakshmi Madam just asked.
You can, mostly we prefer milk in the sense that it gives you adequate calories and protein, but you can also modify other complementary feeds, and that only problem is it will not flow. Usually the mother is giving, so we always tell them that under gravity, let it flow so that you are sure that it is in the stomach. But if you are going to use for a semi-solid food, then you would definitely require an infusion pump, or you would require your staff nurse to really give the feed in, which may not be always possible in the government sector.
Yeah, that's what. Semi-solid, what, madam? Cereal pulse protein mixtures or something?
SAT mix also.
Mix, yeah, you make it and you give it. Okay, okay. Thank you, madam. It was really, any more questions, Lakshmi?
Ma'am, that's it, ma'am. So all the questions have been
We are
addressed.
On time, madam. Exactly on time. Real Shatabdi Express, it went on and all clarity, madam. We have got all the slides and such a great clarity. We'll be calling you for some other program for a panel discussion shortly again, madam. Thank you so much, Shija, madam. Good night. Thank you, Lakshmi, for coordinating with the Shija, madam, and making this program a great success. Thank you.
Thank you so much, ma'am. This would not have happened, obviously, without the support of our president, ma'am, our office bearers, Nisha, ma'am, Dr. Subbu, and of course, great thanks to Shija, ma'am. So it was a very enthralled audience, I guess. So we've had 100 participants across YouTube and Zoom. So such a wonderful presentation. Even we had something to learn from every single slide. So thank you so much, ma'am. And this record is available on YouTube, and people can access it at any time.
You also, madam, you will also give the link to you. You can circle. It's really useful because this topic has not been dealt in detail much, madam. It is a real very rarely we get people to talk with such great authority too, madam. Because you are both in but one thing I was wondering, because though we are in Tamil Nadu, though we have enough admissions, for example 50 admissions per day, and our inpatient strength is around 830, we don't see kwashiorkar, madam. We do see Sam, but you showed all the 3 children with kwashi. We don't see, madam. I have not seen kwashiorkar for the past maybe quite some years, madam. Very rarely. I was really wondering how come in Kerala you see kwashiorkor so much.
And the history or the diet history would be same for all these babies. They don't come from poor families. The diet history is breast milk has been stopped and it has been replaced by a complementary feed. They've completely stopped the milk because the idea for them would be if cow's milk is given, you get infections, so they don't give cow's milk. And they don't want to give formula because they believe that formula also causes increased respiratory infection. So they landed giving ragi in the bottle. The history is same. They cross all these species, ragi in the bottle. Not because of this thing. And you really badly need a nutritional this thing for the public. It's completely preventable. When they come to you, it's completely preventable.
Okay. We are comfortable with the cereals pulse protein mixture here. All these kanji, sattumavu kanji we call here, madam. So all that is being given to these children and we don't see kwashi. That definitely we see. Thank you so much again, madam. Thank you so much.
Thanks, ma'am. Super talk.
Thank you so much. Again, thanks to our IAP CCBs, OB and EB. Thanks for the support. Thanks for all the students who have joined. It must have been very useful for you. So until we meet next month, it's all